ಚೇತನ ಶುರು ಮಾಡದ?
Deepa ma'am, over to you.
Okay.
Thank you so much, ORDI, for inviting me. And I'm just going to visit the very basic disorders which are covered in newborn screening. The objectives of my presentation obviously would be to make you understand what was the evolution of newborn screening across the globe and its landmarks in India. Why is this a public health program and what does it actually decide upon? What is the difference between a core panel of disorders and an expanded panel in terms of a national priority? To understand criteria on which disorders should be prioritized for a country, these disorders, since they were originally laid down in 1962, have undergone revision in 2008. Then to understand how to collect a dried blood spot and transport them out, a little bit of point of care tests, and then of course, what is a screening test, what is a reflex test, what is a second tier test, and what is a confirmatory test. And then the lessons learned we have learned so far in newborn screening. So just let's look at the world's paradigm. So you must be knowing in 1960, it started with Professor Robert Guthrie, who did, you know what? A microbiological essay, not even a biochemical essay, for a disorder with which his grandchildren suffered. These grandchildren were fair in color, depigmented skin, and had a little light iris, and they were mentally retarded. And he decided to go on and check his grandchildren, and found that they had a disorder which we now know as PKU. So with this, many of us still recognize the filter paper cards as Guthrie cards. And that's very commonly used in our literature. So the template screening became for PKU, but the basic screening across all countries which were developed started with congenital hypothyroidism in the year 1965. This was closely followed. You would see less than 20 years difference with the first program, which was done by Dr. Meena Desai at B.J. Wadia Hospital, Mumbai, where she used cord blood TSH for newborn screening. Immediately after this, many states started going into newborn screening. And actually, a newborn screening committee was formulated in India, which contained 3 Indian members and 2 international members. Closely following this came 2 programs, Mission NEEV and Shalabam. And these were comprehensive newborn screening programs which screened public sector births. It started in Kerala and in Delhi in almost the same year between 2018 to 2022. But Delhi was very fortunate, and we really thank ORDI for that beautiful portrait they gave us of Mission ANMOL here, because it actually looked at many more disorders and looked at optimal care of a live newborn. So our original name, Mission NEEV, NEEV in Hindi you all know means Bunyad or foundation. And therefore the tagline was Great Nation, Strong Foundation. But ANMOL means optimal life care for advanced and optimal life care for a newborn. So what are the types that you do? So if you broadly look at the tests, there are some tests which are conducted on the filter paper, which are called sent out tests. These tests you sent out because they are done at another laboratory which is not close to your house, maybe regional or maybe district level. In these, the common disorders that you check are congenital hypothyroidism, congenital adrenal hyperplasia. Now, there are areas in which G6PD is deficient, and there are areas in which sickle cell is deficient. So you can look at one of them, both of them being common. G6PD as an enzymopathy and sickle cell anemia as a hemoglobinopathy. Followed closely by galactosemia, biotinidase deficiency, phenylketonuria. MCAD is a different medium chain acyl CoA dehydrogenase deficiency is difficult because it requires a totally different platform, which is called the LC-MS-MS, for which we know colloquially as tandem mass spectrometry. So the core panel actually means the tests that should be conducted universally in each and every newborn. The first message. Core means test for every newborn. No choice whatsoever. These include congenital hyperthyroidism, congenital adrenal hyperplasia, G6PD, and sickle cell anemia. And I'm just going to take you through the first of them. So the congenital hyperthyroidism, most of us ask this question, why do we use TSH as a marker? Why not T4? T4 is actually what's going to act at the periphery. Now remember, the hypothalamic pituitary axis acts on the thyroid. Now, if the thyroid is either not there, or is hypoplastic, or is sitting somewhere else, it is basically ectopic, the problem, or it is well sitting in its place but not functioning. That means the problem is with the thyroid gland. And whenever the problem is with the thyroid gland, what will happen is there will be a negative feedback to the pituitary. So once there is a negative feedback to pituitary, pituitary starts putting in more and more of thyroid stimulating hormone. So if in your population 90 to 95% cases occur because of disease in the thyroid gland itself, TSH will be a good marker, and that is the phenomena across the world. But yes, there are three conditions in which TSH will not be a good marker. If the cause is at a pituitary, obviously pituitary will not check TSH, it will not release TSH. Here T4 will become a marker. T4 will also be a good marker, in which case you have some time in calling up the baby. You can add T4 as a primary marker, and therefore this is called a reflex test. A reflex test to bring the sensitivity up of your primary test. That's what's called a reflex testing. Though it would be really good to use both together, but both together are not cost effective as yet for low middle income countries. Secondly, remember, we collect these samples on dried blood spot. So all those of you who use a dried blood spot would understand that from the blood spot, you need the blood to elute. And from that elute, you actually check the levels of the analyte. Therefore, the recovery from a dried blood spot can vary from 68% to 90% and will never equate the serum. So what I'm going to discuss further on as cutoff values are on dried blood spot. If you want to convert them to serum values, you have to multiply them by 2.2. Correct? I think two important messages. A primary marker, a reflex marker, difference between units of dried blood spot and serum. Now, the biggest question private practitioners ask is, see, in our case, the babies live with us for only 24 to 48 hours. Then they go and see some other practitioner. Very, very important to understand that the cutoffs in all low middle income countries have been tailored at 24 hours without the noise of a significant number of false positives. So the importance of a screening program is do not miss a baby. We know using TSH, we will be able to cover up to 95% of cases, leaving those babies who have central hypothyroidism, leaving those babies in whom TSH does not act on its receptor, leaving those babies in which T4 does not act on its own receptor. So it is not 100% sensitive. That's very, very important. So don't say that you've checked for primary hypothyroidism using TSH. This child doesn't have thyroid. It's not all or none phenomena. 95%, yes, it's true. 5% there could be causes where it could have been missed. You would be surprised that there is a state in the US. This state is called the state of Texas. It does the screening at 6 hours of life, and it is mandatory to screen all babies before discharge. So for congenital hypothyroidism, the prevalences you can see vary between 1 in 2000 to 1 in 1000. And you would be surprised that now centers like Sydney, Manchester, London, Bellevue, Seattle, Texas have started having, which were having an incidence of 4,000, 5,000, are having an incidence of 1 in 2,500. What has happened? Have they lowered their cutoffs? No. The cause is actually lot of Southeast Asian migration. And what do we do when we send our children to India? Give them one important message. Marry an Indian, please. Marry somebody who is from our culture and understands our culture. The chances in thyroid hormone formation after the gland is formed are the steps of iodination, deiodination, and maturation. All of these steps are actually covered by an enzyme. So the chances that two recessive alleles from the same community in the phase of dishormonogenesis will make an autosomal recessive condition come up higher is one of the reasons why these states where there is a lot of Southeast Asian migration has really improved or increased the number of babies diagnosed with hypothyroidism. The other reason could be that they have lowered their cutoffs. So let's look at what the cutoffs are. Now, very, very important 3 statements. Please remember this. Any value, you get more than 80 million international units per liter. Start treatment immediately. Do not even wait for venous thyroid profiling. Values above 20, call the child. First, retest on the same specimen using another spot on the filter paper so that you have ruled out artifactual, pre-analytical and analytical issues. If it is between 10 to 20, it's the ambiguous zone. Many developed countries have now lowered their cutoff to 8 million internationals, so their calls are much higher. So at 80, you start treatment. At 40, you call immediately for venous profile. And at 20, you can wait. Okay, let's see. Not all of them will be permanent. Some will be transient hyperthyroxanemia. What do you do? So you had a first test, a value of the first test, and now the confirmatory test. The confirmatory test is T4, TSH, and T3 levels. You may not do FT3 and FT4. And this cannot be done by the same technology, which is immunoassay or time-resolved fluoroimmunoassay. It should be done either by chemilucence or by radioimmunoassay. So the message is the test which you use for screening should not be used for confirmation. They should be totally different so that the same issues do not cause them again to have a false value. Now, if you were in a peripheral hospital and you had a strong feeling that I have seen this child, and this child, has an open posterior fontanelle. Now, how do you know it's an open posterior fontanelle? It's usually more than the size of a eraser, a pencil eraser, a small eraser. So, if you look at the posterior fontanelle and the size of the fontanelle is more than a rubber or an eraser, it is open. Specifically, if it is a term baby. So, you can look at the open posterior fontanelle. The second very important area is to do an X-ray knee. Now, normally the lower femoral epiphysis and the upper tibial epiphysis appear at 34 weeks of life and they become very good ossification by term. So, if you have no epiphysis, that means this child was significantly retarded. Correct? So you should look at the epiphysis of the distal femoral and the upper tibial and measure if both of them combined measure more than 7 millimeter, and if the T4 is less than 70 and their value is less than 7, very easy, 70 picogram per liter, 7 mm. That means that there is severe affection of the thyroid gland, and even the mother's thyroid has not been able to actually advance the age of the child as far as skeletal maturation is concerned. Then what happens after you do the X-ray? You should do an ultrasound. But remember, the ultrasound requires a smaller probe of 9.6 hertz to 12 hertz. And not all centers in this district have the ultrasound. It is most ideal. So ultrasound will tell you if there's a gland there, or if it's a small gland there, or there is no gland. Now, suppose there is no gland. You have to rely upon radioiodine or technetium scan to differentiate whether it is an agenetic gland, it is a hypoplastic gland, it is an ectopic gland, or if there is a good acha gland sitting there. That means there is a gland in situ. But there is a very big catch here. Now, in this child, which I showed you earlier, as 80 microliters per liter, you have started therapy immediately. Now, suppose she comes for a scan at day 7 of life. Whether she has a gland or she doesn't have a gland, the technetium will show that there is absolutely no gland, because the iodine will not allow the uptake of per technetium, and all your values will actually say that it is an agenetic gland. So the key message here is do a venous confirmation, do an X-ray knee, do the ultrasound, do the technetium scan within 7 days of starting the treatment. And if the 7th day is over, of 10 to 15 microgram per kg per day of L-thyroxine, do not do a scan at all. Unless you get an ectopic scan, ectopic gland, even that will not be picked up. Do not do a technetium at that time. So what do? After you have a screen positive, you have confirmed by venous testing that the levels for that gestational age of TSH are high and T4 are low. How soon should you start giving treatment? It should be within 14 days of birth. Now, why this sacrosanct figure of 14 days? It has been seen that two twins one with hypothyroid and one without. If they were treated within 14 days of birth, a couple of such diets had almost equivalent intelligence quotients at 5 years of age and developmental quotients also at 5 years of age. So the time to treatment is good. You can do the test, you can do the retest, you can do a venous sample, you can do the ultrasound, you can also do the technician, barring 80 plus babies. What is the biggest disaster here? Every month, if you do not treat hypothyroidism, a baby loses 2 to 5 IQ points. And this is irreversible. Even if you start L-thyroxine, it will not get reversed. You have to follow up for anthropometric parameters, developmental quotient, and biochemical follow-up. Second question. I have picked up this baby at birth. I have not done a scan. If I did a scan and I got an absent gland or an ectopic gland, I do not need to evaluate this child again for at 3 years of age because he will never form good levels of thyroxine. But suppose there was a gland present there and some of these steps of deiodination, iodination were faulty, or if there were some maternal antibodies which went and blocked the fetal thyroid receptor, then I cannot dare stop L-thyroxine till the age of 3 years. Now, why this 3-year figure? It's because 99.5% of the brain development occurs at 3 years of age, at which point of time you can actually give a short break. This short break is 4 to 6 weeks. Then you again repeat L-thyroxine and do a scan. If FT4 is still, or TSH is still less than 10, more than 10, it confirms permanent congenital hypothyroidism, and this baby will require treatment lifelong. So this was the basic plan in the first disorder, which is called congenital hypothyroidism, forms a template disorder because number A, there is significant morbidity associated with the disease. Number 2, the morbidity is completely preventable because the mother's thyroid hormone takes care of the baby till birth. Number 3, TSH is a very good test. Number 4, T4 thyroxine is easily available. Right? Number 5, you have 14 days, a latent period in which you can do the confirmatory testing and act. So these were the WHO, Wilson, and Jugner criteria. It fulfills all of the criteria laid down in 1960. Correct? Are we going to take questions now or questions later?
Ma'am,
ORDI?
we have the question. We have a separate Q&A in the end, ma'am.
Okay. Right? So please write down whatever comes to your mind. And remember, no question is stupid. If it has come to your mind, it has to have some scientific basis. Now, coming to the disease, which is very, very difficult for a metabolic clinician or a physician, is congenital adrenal hyperplasia. Now, why do we call it CAH? Because in CAH, the mutations impair cortisol. So, like TSH, when there is no cortisol production, feedback goes to the pituitary. Pituitary starts pumping in adrenocorticotropic hormone. When so much of ACTH gets collected, the adrenal cortex starts becoming larger, and therefore it's called congenital adrenal hyperplasia by the same negative feedback mechanism. Okay. Now here, very important tool. The points in red are very, very important. It can manifest in infants, in children, or even in adults, depending upon whether they have cortisol deficiency, how much is the deficiency, is it accompanied either with a deficiency or an excess of mineralocorticoids and sex steroids. That means both under-virilization and over-virilization are aspects of different types of congenital adrenal hyperplasia. So the entire CAH spectrum manifests in infancy with a salt wasting crisis. And I'll just show you how. So the most common form of this is 21 alpha hydroxylase deficiency, which accounts for 95% of the cases. Clinical presentation varies by the enzyme defect, ranging from ambiguity in genotypic females. Now here there is a very important catch. The catch is that if it is a male child, there is no sign, clinical sign on the baby. There might be a little increase in scrotal pigmentation. That's all, which is not picked up by most of the residents. But if it is a female child, the child may have virilization of varying stages, from PREDA 1 to completely PREDA 5, a male phenotype. But when you do the karyotyping, it is XX. And you know that this is probably 21 alpha hydroxylase deficiency. Now, why was Australia, England the last to start using 17-OHP or 17-hydroxyprogesterone as a measure of CAH? There has to be some problem with CAH. Yes. The problem with CAH is that CAH is not a single peak on any of the systems. With CAH, all these markers, 11-deoxycortisol, deoxycortisol, pregnenolone, progesterone, dihydroepiandrosterone, all of them go and make the same peak. So you really don't know what is coming up, right? So if a baby is born premature or in a stressful situation, is of low birth weight, lower gestational age, mother has received steroids for maturation of the lung, or you've taken a dog from the EDTA sample, not directly from the ERE. All of these factors can affect the results. So there are so many confounders. So at birth, if you collect the sample from the cord, you will have a very high value, because the biggest stress to the fetus is the stress of birth. Now, what people have done is they have studied how to go away from this problem. And those who know first trimester screening know what they did. They converted it to multiples of median using ethnic-based gestational age, birth weight percentiles. And now you have this data from India. So this data, the value of 17-OHP, the positive predictive value in low birth weight sick newborns is as low as 3%. And many people find it difficult to get the baby back and resample the baby. So you have to find out other methods of testing. Remember, it is the analyte and not the lab which is responsible for this lack of credibility. So what should you do? So I told you all coelution with cortisol, deoxycortisol, and all the other things which may cause. So you use second tier testing. You can do the second tier testing on the same blood spot in which you did the primary 17-OHP. It will separate cortisol, 17-deoxycortisol and 21-D. That's all. It will not separate the progesterones. So it's a good second tier test. So you know the sick babies are those with cortisol high, right? So you will say, oh, this is a false positive for 17-OHP. I need not worry about it. And this has to be done on the tandem mass or LCMS-MS platform. This is then becoming a second tier test. Second tier, you're using the same filter paper. In T4 also, you use the same filter paper. The confirmation there with venous sample and chemilucence. The confirmation here is steroid profiling on serum. Sorry, this is not blood spots. This is serum. Okay? I'll come back here. So it's steroid profiling on serum, and you can also use urinary steroids. Okay? And that's one way. So the reflex test is carried out on the same sample. The second tier can be carried out on the same sample, but the confirmatory tier testing is on a different sample and you're using this. The incidence from various studies are very high. Most of this.
Ma'am, sorry to interrupt. Could you please put in the presentation mode?
Okay, sure. Sure. So,
Yeah,
it is,
fine.
you can see, can you see now? Right.
Yes, ma'am. Yes, ma'am.
Yeah. So you would be able to see the degree of virilization in the upper phase, Prader's type 2. Anybody would see that the vagina are well formed, but posteriorly not well fused, but the clitoral mygale is there. So if this can be tackled at 9 months to 2 years of age, these children grow up to be reproductively healthy, intelligent females. And that's why in no other country, barring our country, you see this large number of disorders of sexual differentiation. If treated, if detected early, it can be treated. So what should you do? You should counsel the distressed family. In most of the female newborns, because it is evident at birth, screening is immaterial. But all the males, because this is an autosomal recessive condition, die between the second week and third week of life with a salt wasting crisis because they do not have the mineralocorticoid function. So they are misdiagnosed as diarrhea and sepsis, and they succumb to the sepsis. Key factors are hyponatremia and hyperkalemia in these newborns. These two disorders in a male newborn, very important to detect a positive congenital adrenal hyperplasia very, very simply. What should you do immediately? Start hydrocortisone, and if there is an element of electrolyte abnormality, or there is shock, or there is fluid depletion, intravascular volume has gone down, start hydrocortisone. Hydrocortisone is given in the dose of 15 milligram per kg in 3 to 4 divided doses. Do not substitute hydrocortisone with either prednisolone or dexamethasone. Very important because it characteristically mimics cortisol completely. As a pediatrician, you should monitor electrolytes, blood pressure, and growth parameters. Ideally, also should do plasma renin and aldosterone activity to monitor how good the fludrocortisone is working, and start initiating plastic or pediatric surgery referral for clitoral resection. I again, common messages. First tier test on bright blood spot, 17-OHP. Second tier test on bright blood spot, steroid profiling. Confirmatory test on serum, you can do by LCMS-MS, is separating all the steroids, including the sex steroids, and will give you a good resolution of separating cortisol from 17-OHP, and will tell you which was a stressed neonate and which was a neonate who actually had congenital adrenal hyperplasia. Okay, fine. You can store these samples and finally also find out the genotype of the case. Very importantly, if you start giving the mothers with a previous sibling having CAH, dexamethasone at 8 weeks of life till term, their female child who would have been born virilized had she not gone ahead with a prenatal diagnosis, the virilization was completely prevented. So if you do not have facility for CVS, do not worry. Put these mothers on dexamethasone at 8 weeks of gestation. Right? Now coming to G6PD, frequently been asked, what is the effect of G6PD? Yes, it exacerbates neonatal jaundice, but very important to remember that it causes acute renal shutdown with intravascular substances, certain drugs and foodstuffs. So I have no way to interact with you, but there is something that all of us use in the hands, in the hair, and get dressed up on certain festivals and in all marriages. What is that substance? Henna, mehndi. Now, this mehndi can cause jaundice in G6PD deficient individuals. And despite this being an X-linked disease, 18 to 19% of picked up babies are females. They would have no idea and they would just go and apply a good patch of henna and you get admitted with a renal shutdown. Oh God, what happened? Right? So it's very important that some herbal things, it has been seen that when these babies suffer from certain viral fevers, enteric fever, dengue, and particularly COVID, many of them went into an acute renal shutdown, even when those drugs were not given. Right? So there is a list of drugs which do not have to be given at all. And there is a list of drugs which have to be given for caution. So for caution, even paracetamol is a drug and aspirin is a drug with caution should be given only in the titrated doses in the particular duration that you see. So it is not a disease which requires any treatment, but requires lifelong monitoring, carrying a red alert that, look, I have G6PD, don't give me these tablets, don't give me these injections, I will not apply henna, right? And I will not eat the broad beans now. Big Market and so many other companies have started bringing to India. Okay. So coming to the next disorder. So these three core disorders go without saying, should be done on every newborn. Okay. Coming to what our Honorable PM has announced is elimination of sickle cell anemia, which is much common in the tribal areas. But what we have is beta thalassemia. And a decade from now, we used to think, see, look, all of the hemoglobin in the period of newborn is HbF. Now, if it is HbF, how can I find out thalassemia? Right? So, just to recapitulate, HbA starts forming at 34 weeks of gestation and steadily increases till term. So at term, you can look at the fraction of HbA to HbF, which is possible by capillary zone electrophoresis. If you find that there is no HbA at all, there are only two possibilities. Either it is thalassemia and the entire hemoglobin is HbF, or there is hereditary persistence of fetal hemoglobin. That is why there is no HbA. And then you can do a molecular test on the same filter paper and see how easily you can pick up beta thalassemia on a dried blood spot specimen, right? Now, sickle, beta thalassemia is very common. I don't want to repeat how many babies are born every year with thalassemia. Coming to sickle cell anemia, 15% of the world's neonates with sickle cell anemia are born in our country. And I've shown you in red the areas which are dense. So you have Gujarat, Madhya Pradesh, Odisha, Andhra Pradesh, Maharashtra, an entire belt, and of course Karnataka. A big belt with tribal population, inbreeding, and initially an area of malarial endemicity. While in the east, which is say Calcutta, northeast, HbE disease is common. So you have to understand there are zonal preferences and you have to understand difference between a thalassemia and a hemoglobinopathy. A thalassemia is a quantitative defect in thalassemia, alpha thal chains or beta thal chains. If it is less number of alpha thal chains, you call it alpha thalassemia. If there are less number of beta chains, you call it beta thalassemia. But if there is a structural change, that means a nucleotide change in the sequence of the HbEB gene, you call it a hemoglobinopathy. Very important. So sickle is a hemoglobinopathy, while HbE is a combination of both a hemoglobinopathy and also a thalassemia, right? So qualitative and quantitative defects and our Honorable PM's mission to eliminate sickle cell. Now, what is the difference in sampling for blood cell disorders and the other disorders? The punch that you use is slightly bigger for hemoglobinopathies. Samples which are less than 1 month old can only be used. Once the baby becomes more than 3 weeks, he starts forming HbA2. So you will have 3 fractions, HbF, HbA, and HbA2. And you will not be able to differentiate. So it's best used within the less than 3 week period. Now, capillary electrophoresis with high throughput has a very good method. I'll just show you. It indicates the different zones in which they will coelute, right? So let's see this. Now, this red thing here is HbA, and the green peak here is HbF. If you can read, yet you have Bhat's here, N12, N11, NA, N9, N8, and NF. Right in the center of NF, that means the fetal hemoglobin, the peak is going there. And look at the lower down. This is a term baby. So you have HbA, which is 22.3%, and HbF, which is 77.3%. So this is a perfectly normal. Correct? Look at this. You have HbA, which is 22.8, HbF, which is 69.5, and another peak at HbE, which is 7.7. So HbE, HbS elute totally separately. And from the dried blood spot, you can find out which disorder it is. Not at all difficult, right? So what is the action plan once you have a positive screen? Always confirm by another method, which is venous blood sample using either HPLC or capillary zone electrophoresis. Confirm the parents what has been for both HPA and any other disease. Ask history of any missed IUDs manifesting as intrauterine eye drops, which occurs in alpha thalassemia. The variant does not pick up alpha thalassemias at all. It can detect HBH and HB bars. And now sickle cell as a treatment with hydroxyurea. That's why it's important to pick up these children to prevent bone crisis, aplastic crisis, sequestration crisis. But what about thalassemia? There are many parents whose siblings have yet not married. So that acts as a trigger for a cascade. You start treating the entire family and prevent the birth of another baby with thalassemia. So there are a lot of advantages of screening for hemoglobinopathies. Coming to phases 2, which is galactosemia and biotinidase deficiency. The data range from 1 in 16,000 to my unpublished data of 1 in 60,000. There are only 2 or 3 disorders in which mother's milk is completely contraindicated because it contains lactose and galactose. So galactosemia is a disorder in which mother's milk is not to be given at any cost. The analyte that you check can be 2. We'll just show you. And what does it lead to? It leads to gram-negative sepsis, development of cataracts, pseudotumor cerebri, and a bulging presentation. For another variant, the presentation is cataracts. So, galactosemia can be checked by using total galactose or the enzyme GALT. If you use both in combination, it gives you a very good idea. But most of us in India use T-GAL. T-GAL because the enzymes, if it's summer, if you leave them open in room temperature at 45 degrees or 48 degrees, they become baked and they show you low values. So it's better to use T-GAL. One important precaution is do not take the T-GAL sample immediately after breast. Take it before the next breastfeed. Make sure that this sample is taken, and that's not very good for newborn screening. But after you prick the child, you put the child on the breast, even if the child is crying, the child will stop crying. So you have taken that window to find out which baby is yet not fed and will not give you false results. So you can use both the enzymes and you can give them soya milk, which is fortified with everything and available at any nook and corner of the country now, and also produced by nutraceuticals supported by FSSAI. Coming to the fourth disorder, I have clubbed the hemoglobinopathies and thalassemias together. The fourth disorder is biotinidase deficiency. This actually presents with seizures, hypotonia, feeding problems. Look at this, all optic atrophy, ataxia, and alopecia. And they have seborrheic dermatitis, cutaneous plaques over the flexors and perioral regions. The other point, it can be profound, less than 1% activity, or partial, between 1 to 30% activity. Now, what should we do? Is it only the profound ones that we treat and leave the partial forms? What happens? If you look at the early onset options, they present with this classical phenotype. You give them levetiracetam, phenobarbital, second line drugs, they don't respond. The moment you start biotin, the EEG becomes perfectly normal. The hair starts regrowing. The tone improves. Feeding problems go away. What is irreversible is optic atrophy and hearing loss. You can't get that back. Therefore, it has to be done right at birth only so that you can give a hearing aid. Until the cochlear implant, the hearing aid can actually make them understand language. If they understand language, they will speak. If they do not understand, they will be deaf and dumb. And the message is very clear. We should not be deaf to deaf. We have to be not deaf to the deaf people. We have to vow that we will prevent deafness. Right? This is an important cause of deafness. The partial forms, can go to an adult metabolic physician and present as neuromyelitis optica, Devick's disease, Wernicke's encephalopathy, or multiple sclerosis. A very important message. It's the time adult neurological people should start thinking, do I have a metabolic disease? Have I missed that disease? And that's what happens with partial forms of biotin deficiency. Why have we included in the phase 2? It's simply because the prevalence is less. Also, in treated patients with galactosemia, many females who grow up develop premature ovarian failure at about 40 to 45 years of life. And once all our things are in place, the core disorders, the treatment of these disorders is hardly anything. We can add this 5-bunch bundle. Okay, 3 mandatory, 2 depending upon the IMR, the availability of checking for galactosemia, confirming biotinidase by an enzyme assay. A very important method in biotinidase. People say, I suspected biotinidase, epilepsy was going on, I did not get the biotinidase assay done. Can I give biotin? Oh, yes. Biotin will not interfere because the recycling agent. It just recycles the biotinidase. The levels, if they are low, will remain low. You will not get a false reading of high value. So you can start biotin even at suspicion at the dose of 5 to 10 mg per day and go up to 20 mg per day if there are other systems affected. Very, very important messages. So first test was biotinidase enzyme assay. Second test is confirmed galactosemia, either by molecular means or by using RI as one of the detectors in high performance liquid chromatography. Much more important to confirm galactosemia by molecular method. Similarly, biotinidase has a simple serum enzyme assay which any center can easily develop on spectrophotometry, which is available at all district hospitals. Not at all difficult. So for inclusion for our country, these 5 become the key disorders. Now people ask, everybody asks, the world started, Guthrie started treating with PKU. Why are you not thinking about PKU? You don't see PKU? No, you see PKU. Why have then we stopped? So, the data that we have from more than 240,000 babies between 2014 and 2017, done with the help of Professor B.K. Thelma, we did not get a single positive case. Similarly, Kerala did PKU for 4 years. Did not get a single prevalent positive case. So the zones that we have touched till now do not have a high level of founder mutations having PKU. Therefore, we have kept it in the background. But it can also be done by any of the methods. And now that we have diets in India available for PKU, if a zone has PKU with a significant evidence, you should also start screening for PKU. But for us, we are not taking it as a priority because we didn't get a case even 1 in 1 lakh, 1 in 2 lakh. So it's important. I am not talking about the other hyperphenylalaniemias. I am talking about classical phenylketonuria, in which the value of phenylalanine is more than 1,000 micromoles per liter. So coming to what was next and what is the expanded panel. This was the core panel. What is the expanded panel? Expanded panel was screening with tandem mass spectrometry, in which from one drop you could do 56 tests. And now today you can do 90 tests. So it shifted from one sample, one test to one sample, many tests. These samples could be biochemically tested, tested on DNA. We are just 63 years behind the world in expanded screening, and Delhi has just launched its pilot Mission ANMOL, which includes expanded screening. It can screen for disorders of amino acids, organic acids, and fatty acids. So if it is not in your state, when should you do it? If there is first cousin or uncle niece marriage, if there has been a demise because of any other cause not known. In one study, it was postulated from Tamil Nadu that about 11% patients, newborns in which mortality could not be explained, a significant number of them could have been because of one of those disorders which fall into amino acid, fatty acid, and organic acid. But currently, we should start screening all these places where these sick care newborn infants get admitted, which is sick care newborn units and NICUs, more so now that we have diets available with custom duty exemption. These are not against breast milk. You can give some amount of breast milk, and these are called foods for special medical purposes and are covered under National Rare Disease Policy in the group 2 disorders. So this can be immediately introduced in the SNCU. The chances of saving a baby are 1 in 300. And now with the NRPD, the cost of treatment has completely gone off. So who should collect from where? I will just show you. You can collect by any health worker, could be a paramedic, but in critical areas, it should be either a nurse or a doctor, anytime after delivery for 24 to 48 hours, or to discharge, whichever is later. Question comes of consent. Will they understand what G6PD is? Will they understand what galactosemia is? True informed consent cannot be given. So like we never ask for BCG, for DPT, for polio, best is opt out. It is a public health program, right? For saving babies without any visible defects. So please screen these babies right at birth. People ask, why not a cord sample? Now, of course, missed opportunities are less. It's painless for the baby. Large quantity of blood is available, but you cannot do anything on 17-OHP, phenylketonuria, any other disease on which milk is required, because milk has not been fed to the infant. So all the other metabolic conditions will go. One, you have good tests for enzymes, but not for substrates, which depend upon breastfeeding. Though the report may be available at discharge. The disadvantages are you cannot check home-based deliveries, metabolic deliveries cannot be done. You require round-the-clock professionals because birth can occur at any hour. They are affected significantly by perinatal factors. And once you start a program in the aeroplane mode, that is taking cord blood, it's like an aeroplane, just taken and sent. While heel prick, you go explain to the mother, baby looks well, you tell him, look, I want to take the blood. Reinventing the wheel is not possible. All countries who are doing cord blood have shifted to heel prick because you would like to expand tomorrow. So screening should be done from the lateral part of the heel. You require a dedicated lancet. This lancet is a sling lancet and not the lancet available for blood sugar, because you want nearly 3 to 5 drops of blood. This is an FDA approved lancet which is auto-destructible. Therefore, cannot carry infection from one baby to another. You can't prick another baby. You just touch the filter paper with the heel, not even touching the heel. Just get it close. The blood is so cohesive that it will come and fit into the filter paper, and this is what it looks like. Now, a very important thing you must have noticed is something black here. Those bars. These are the bars of anonymization. So what will be done at the lab is the demographics will be separated from the blood spot. Reason being, tomorrow if you collect Amitabh Bachchan's blood and store it on filter paper, you can clone him after 20 years. You will say, no, I want a child like Amitabh Bachchan or Shah Rukh Khan or one of our ministers. So this is a good source of DNA. You have to anonymize the sample and remove the filter paper. And all you need is a simple sheet to transfer these samples. Of course, whenever you get an abnormal result, you always repunch before you recall. Once you recall, you do a confirmatory testing. Treatment is initiated. Turnaround time is of great importance. Percentage of FIST babies actually affect the credibility of the program. That is not the end. Follow-up of the cohort and long-term study is important. Linkage of each baby via digital health mission is a possible solution so that even if he goes to some other states, it's important. Do I have time or should I wind up?
Ma'am, how much more? Another 10 minutes
Just
would be fine, ma'am.
10 minutes would be fine.
Yeah,
Okay.
because it's really interesting and we did not even realize that you have covered 1 hour. It's really
Okay, sorry.
resourceful.
Okay. So the next point of care is congenital critical heart disease. And now if you talk to any Diksha fellow, he understands what pulse oximetry is, right? So pulse oximetry, if you use in a newborn, you use postductal and preductal. The preductal is your right hand and the postductal is any of the 2 foot. And you measure saturations in 1 foot and 1 hand. Okay? So this will actually give you an idea of critical congenital heart disease, which means babies who are going to die in the next 28 days of life. So if you want to attain SDG goals, as India has just committed in this WHO 2026, how will you do before you cater to CCHD? So these are children who have pulmonary atresia, hypoplastic left heart, aortic valve stenosis, pulmonary stenosis, tetralogy, pulmonary atresia, or TAP-VC are the disorders. So the principle is of deoxy versus oxyhemoglobin, which gives you the oxygen saturation. The principle is do screen at all babies, screen at one of the arms. If it is less than 90, it is fail. If it is more than 97, it is pass. If it is in between 90 and 96, believe me, by clinical eye, you cannot distinguish. This is a zone in which eyes defy you. You get 90 to 96, screen other hand. If it is again less than 90, goes for a fail. If it is more than 95, or if there is less than 3% difference between right hand and any of the foot, you have to do two or another screen. Obviously, you will go and do a clinical examination, do a chest x-ray, and do an echocardiography, and look for other associated birth defects, and take this child for surgery. What has been the biggest learning that we have learned? Not only does it pick critical congenital heart disease, it picks up congenital pneumonia, meconium aspiration, early sepsis, transient tachypnea of newborn, and persistent pulmonary hypertension. So these are non-cardiac hypoxemic illnesses. So imagine how much SDG goals can just be achieved by just one pulse oximetry phenomena. Problems, significant numbers. If China can do it in 3 years, why can't we? I think we have equal intelligence. Eco machines, not very cost prohibitive. Biggest problem is trained cardiologists and CTVS surgeons. Many pediatricians can be committed to cardiology, but all CTVS surgeons should have a linked NICU. And I think ORDI should actually look up linkages, creating these linkages and finding out the solutions. A very important message to Prasanna ji and his group. The last, which I'm going to cover, are two: hearing impairment. The frequency is 1 in 2 per 1,000 in low risk babies and 1 in 4 per 100 in NICU graduates. Right? A very simple test like autoacoustic emission can check hearing up to outer cortical hair cells. So you have the outer ear, the middle ear, and the inner ear. In the inner ear, you have outer cortical hair cells and inner cortical hair cells. So up to outer cortical hair cells, OA will give you everything. But if you want to go beyond, you have to do ABBR. And that usually happens when the baby is discharged from a sick care newborn unit or an NICU unit. And the confirmation is by a different technology, which is BERA, which requires a soundproof room. The hearing could be fluctuating, bilateral, unilateral, sensory, or conductive, averaging 30 to 40 decibels or more. At our age, we pick up children only after 9 years, 9 months of life, by the time they've lost their language. Right? So, up to 24% of babies may be deaf. Initially, we used to follow 136 principle. Confirm by 1, reconfirm by 3, and give hearing aid by 6. It has been changed to 1, 2, 3. Confirm by 1, test by 1, confirm by 2, and provide hearing aids by 3. So that at 6 months, when the prelingual phase is over, the baby is able to hear. And the time when you do the hearing aid and the cochlear implant decides how many words, vocabulary will he have. And very important, don't be deaf to deaf. So, diagnostic confirmation is with ABBR. If you get any other syndromic evaluation, follow up with the genetics. If there are craniofacial malformations, take it to a ENT surgeon. Follow-up should be at district early intervention center. Speech therapy will be required even after cochlear implant. So there is nearly 30 years of work from India, multiple pilots, hilly terrains, tribal areas, difficult areas, but there is a large network of mobiles. IT is there even where nothing is there. Now there are very cheap network plans. China and Sri Lanka could receive 94%. And in 2026, the focus of WHO is to implement newborn screening. So, एक हिंदी में गाना है, इस धरा का सितारों से मिलन होके रहेगा. वो सितारे हैं हमारे, वो नन्हे बच्चे, अनमोल बच्चे, जिनकी जिंदगी हम बचा पाए हैं. So newborn screening is an important public health program akin to immunization. It includes screening of all newborns with blood spot and point of care tests. Expanded should be done in NICUs and SNCUs. We should phase it out. When implemented in a national scale, you will be saving 8 babies per minute in our country. A small program, a very small slide from my earlier name program, Mission NEEV, and that's the end of it. For those who understand Hindi, is dhara, dhara means dharti, ke prangan, prangan means आंगन में. इस धरा के प्रांगण में मैं मजबूत नींव से आया हूं. कुछ कारण मंदबुद्धि के, सब तो नहीं, कुछ मैं स्क्रीन कराकर आया हूं. दोस्तों, तुम भी साथ चलो मेरे, कुछ बूंदों की ही बात सही, बहुत बच्चे बच सकते हैं, ये कोई छोटी बात नहीं. नवजात सर्वत्र स्क्रीनिंग से हम आगे बढ़ते जाएंगे. आंखों से जो ना पकड़ी जाए, ऐसी विपदाओं को सुलझाएंगे. आओ नवजात स्क्रीनिंग अपनाएं. थैंक यू सो मच.
Yeah, thank you, Seema ma'am. It was such a wonderful session. Like even 1 hour went off like just 1 minute for us. And one of your student here in Mysore said that Seema ma'am is wonderful teacher, and I had listened to many of your session, but today, like I was really mesmerized. Thank you so much, for literally making it so simple that this is a diverse group of audience, starting from a very learned to a patient advocacy groups to many more. So you have catered to everyone. Thank you so much. We have question in the chat box.
Yeah,
So
sure.
number one
Ready
is
to
why?
answer it.
Yes, ma'am. Could you, can I start, ma'am?
Sure.
Yeah, why does India not have universal newborn screening for the core panel?
Very honest admission. You require a lot of political support, and this is the only country which has a national rare disease policy before a NBS. So I can only say I was not politically linked.
Yes, ma'am. Yeah, we can experience National Sickle Cell Anemia Mission now. So it could reach because of whatever
Yeah.
you have mentioned. Hope it comes for
Next.
all the
Oh my God.
diseases. Or maybe we should wish that some politician should have a kid with affected so that
I
it
mean,
will
that's how
come.
skits started in the US.
Yes, ma'am. Is choosing a good lab important for newborn screening?
Yes, very important. Because it's not T. You have to do the pre-test counseling, the sample taking. So somebody has to see whether the sample is okay. Sample tracking, to look at whether it's retested, to look at whether it undergoes quality control. That means there are calibrators at the beginning of the 96 well, at the end of the well, and you're also participating in an external proficiency testing. So external proficiency testing gives you coded samples in which you have to decide what is the abnormal analyte. So until and unless there is a QC in the lab, no point sending samples. And this is not a lab test. You need the post-test counseling. You need the follow-up. You need the confirmatory testing. So it's actually a public health program and not a lab test at all.
Ma'am, another doubt. Many times we have seen that the lab has directly told the result, or it has been reached the parent, they are panicking. Still, this is a screening test. It is not a confirmatory test. How to ensure that there is a proper way when it comes as a public health program, how we can ensure that this is rightly handled till it reaches and doesn't cause much panic to the
Correct.
beneficiaries?
Yeah, a part of it I did answer that the lab should automatically build reflex testers. So you have a first analyte, have another analyte. First you retest, then you add another analyte before you call the second wave. That's the first thing that you should do. Second, in all these tests, you should write presumptive positive, indicating that there could be a chance that this could be incorrect. So telling the parents that not all babies who are presumptive positive are confirmed babies and confirmation test is required. So don't panic. Your baby might not have it. That's why I'm saying it's not a lab test. You have to tell everything to them. If you have a positive screen, it doesn't always mean you have the disease. A screen is tied with false positives. And I told you in CH, there are false negatives also, because it doesn't cause central hypothyroidism, peripheral resistance to TSH, peripheral resistance to L-thyroxine, right? So we cannot give promises which are non-scientific. So we write presumptive positive. Please contact the lab provider immediately and go to your nearest physician.
Yes, thank you, ma'am. One more question in the chat box. Siddesh SM. So, is amino acidopathies, organic acidemia, fatty acid oxidation disorder screenings available in India?
Yeah. So in Delhi, under Mission ANMOL, we are doing all of these. It's the first state-led program to do expanded screening university.
What should be the algorithm which has to be followed? Suppose a state has to bring it up. What should be the core? You mentioned CH, and G6PD.
And
Other than that, if the government wants to introduce, what
so
would...
then galactosemia and biotinidase. 5 disorders, definitely. Right? I haven't talked about IRT at all, though IRT
Yes,
would be very important. Cystic fibrosis. I haven't talked about IRT because the analyte has got lots and lots of issues. So for this audience, which was a mixed audience, I
yes.
deferred the IRT phenomenon. Okay. Though IRT would also fulfill the criteria for this. After this comes the expanded. Expanded should be hand in hand for the SNCUs and the NICUs in any state. You can't defer expanded for this set of people. Because even if they die, you have a molecular diagnosis. You can do the reproductive counseling for the next kid. You can do the cascade screening. And if you happen to go under to any COE, you can get the treatment done. So any state which has a COE can have centers where expanded screening can easily be started. And believe me, if I as a pediatrician could understand biochemistry, a biochemist is understanding pediatrics, that's the way we are going to grow. It's an interplay of interchange of knowledge.
Yes, ma'am. Yeah, perfectly said. Yeah, we have another question from Dr. Tarunima Gupta. In a government hospital, can we start a cord blood TSH and 3-day newborn TSH initially?
See, cord, I told you, is only good for enzymes. So by enzymes, I make G6PD, TSH, and lysosomal storage enzymes. Okay. I told you that when we start walking, or when we start traveling in an aeroplane, we really do not want a rickshaw. So if I start today in traveling, now Delhi has, Delhi has got these tele taxis. If all of you have read in the news, in a short while from my house to the airport, if I can afford, I can go by a air taxi. Right? So air taxi is a good method of transport. But we really do not know what will be the offsets. You understand? So it's very important to analyze that you cannot start only 1 or 2 disorders. When you're planning to ultimately amalgamate 5 disorders, of which only 1 you can do on the cord blood. And the 17 OHP is the least reliable at cord because the biggest stress to the fetus is the stress of labor. And just after labor, you get the cord. Cord will have peaking high values of 17 OHP. And every day you will be in doldrums doing second tier testing for 80% babies, spoiling your not only economics but the credibility of the program.
Her add-on question is main concern is loss to follow-up because
So I have been telling all private practitioners, if they get discharged at 6 hours, don't worry, take the sample. If they get discharged at 20 hours, take the sample. See the values. If they are above 20, call the baby back. 80% will not have values above 20. 90%, they will have less than 20 or less than 10 definitely. You don't need to worry. So at any point of discharge, LAMA, transfer or death, the 4 situations, take the sample, right? So that we need to just revise the cutoffs. I told you the state of Texas in US does screening at 6 hours of time. Why? Because they have 3,000 samples per day. I do 800 samples per day. So, you can't keep 7 mothers in one bed. Right? So, no point. You can take sample at any time. You may need to resample, say maybe 3 to 4% of them again. But that's it. So, you will not lose any baby. Sample before discharge, LAMA, transfer, blood transfusion.
Yes, ma'am. Well, another question is what should a general physician should not miss in newborn screening?
See, in newborn screening is actually something which you're doing to an asymptomatic or a neonate looking perfect. So barring the open posterior fontanelle, or what should the person not miss at is the family history of any disorder. So if you have a universal good full-term normal vaginal delivery, 38 weeks, 3 grams, 3 kg, cried immediately after birth. But in the family history, you got 2 similar babies born full term, died at 28 days and 1 year of life. Now, this child will require expanded screening. So, the family history of the child is something any pediatrician, medical officer, district hospital should be asking to decide, shall I go on to the core or do I need to do expand it in this kid alone? Because now I want to save this only kid, either of that index parents or of the immediate family relatives.
Fine, ma'am. Thank you. Another question is, as an NGO, can we start expanded new screening through LCMS platform and how to reach patients for samples?
So, as anything, if you can complete all the 4 tiers. So, the 5 or 6 tiers are pre-test counseling, taking the sample, transporting the sample, understanding the covariates, age at birth, weight at birth, hour of sampling, singleton, maternal risk factors, Apgar score, maternal iodine, maternal dopamine, maternal glucocorticoids, maternal fatty liver, maternal hyperemesis. You're able to do all this. You can send the sample and your LCMS has a quality control performance matrix or is registered with CDC Atlanta, which they have stopped registering. So we're looking for an Indian center to make a QC. You can start. But none of the limbs and the follow-up, the confirmatory testing. If you close the loop, anybody can start.
Thank you, ma'am. Ma'am, I have a question for myself. So, if suppose nowadays couple carrier screening has become very common, suppose both the couple are found to be carriers for any of the enlisted diseases now. So, since now we have treatment for some of these and manageable, so what would be the counseling offered if they are found homozygous in the prenatal diagnosis reports?
Right. So if you get both of them having carriers, I assume of the same disease, you may have 2 situations. They may have same mutations or they may have different mutations in the same gene. Same mutations mean they're homozygous. Different mutations but affecting the same gene is compound heterozygous, right? The chances that they will have an affected child are 1 in 25. That means 1 in 4, not 1 in 25. 25% chance of having another baby. So 1 in 4. So many of the parents ask us, we wanted 4 children. We've already had 1 child. No, obviously all the rest of the 3 will be done. So you ask them, क्या आप ताश खेलते हो? ताश में you keep 1 hukam, 1 begum, 1 ikka and 1 joker and try flashing it. What is the chance you will get the joker? 25%. Right? So for that 25% chance, which is a significant chance, you should go to a fetal medicine specialist at 10 weeks of gestation. First, for which disease you have found to be carrier, you know the mutation, make sure that it has been verified by Sanger sequencing. You exactly know the Sanger report in both the father and mother. Confirm that. That testing can be carried out in the fetus between 13 to 14 weeks of gestation using chorionic villus sampling. And we will look for either the same mutation or if there are 2 separate mutations, both the mutations. The problem comes when the father and the mother both carry the same mutation. They're homozygous. Now, when we are taking chorionic villi, sometimes maternal blood also comes in. Right? So that maternal blood, when we do PCR, it may amplify. And instead of the fetal fraction, we might be checking the Maternal section. Who will be a carrier? So this has to be done in two parts. You have to check what is the status of the fetal sample. Does it contain two mutations? Does it contain one? If it contains one mutation, then you have to check maternal cell contamination. Do some markers in the mother, do some markers in the father, and see if the father's marker are also there. Right? So you have to do a very important prenatal diagnosis by chorionic villus sampling coupled with maternal cell contamination. If they come early in pregnancy, safer termination. If they come late, 18 to 20 weeks, you can do this by amniocentesis. So if they are married, no problem. Come in the first trimester. As
मेरा
early as possible.
कंटिन्यूड क्वेश्चन मैम, सपोज बेबी इज फाउंड टू बी होमोजाइगस, आप बता देते हैं अभी एड्स बहुत सारा ट्रीटेबल है, अभी एथिकल क्वेश्चन है कि टर्मिनेशन करना चाहिए या कंटिन्यू करना चाहिए.
Unfortunately, we have not laid down ethical guidelines to define exactly what is lethal. But if somebody tells me I have a child with biotinidase deficiency, I will say, no, you don't need a prenatal. It is treatable at a very low cost. But somebody who says I can't even give biotin, I am living so far off. The pharmacy, I cannot reach the pharmacy. I cannot rear up a child. There's such a quantitatively big difference. So ethically, for a treatable disorder, I can't offer termination.
Yes.
But these ethics have to be laid down. They're yet to be laid down. What should be considered as lethal has to be defined. For many structural malformations, they are defined. Like for congenital diaphragmatic hernia, what is the lung to heart ratio? Right? We have indicators. But for these metabolic conditions, we really, some of which are completely treatable, and even treatable by a single method like liver transplant or bone marrow transplant or HSCT. But can we really make sure that the HSCT will have no graft rejection, will have no post-transplant problems, right? So we have no ethics laid down as yet. So this question is really very difficult to answer.
Yes, ma'am. Yeah, all the questions are covered, and we have mesmerizing 1.5 hour session from you. And thank you so much for such a insightful session. And on behalf of ORDI, all the participants, and myself, I would like to thank you for giving us such a beautiful and resourceful talk. And this is 69th series of ORDI, and ORDI has been making a huge impact by conducting many such events from stalwarts across India, and we are able to reach you all.
So I think it's due to your goodness, it's due to your vibrational strength that you can connect, and you have been able to help so many families. So I think ORDI does a work which very few NGOs can emulate. So I think that itself is such a big thing. And I can only say my heartiest thanks that you could hear me down for a topic of my interest.
Yes, ma'am. Thank you so much.
Thank
you for your valuable time. And thank you, ORDI, for this event.
Yeah. Thank you, ODI.
Thank you, ma'am. Thanks
Thank
for
you.
this
Thank you,
valuable
Prasad.
time. Thank you, Dr. Deepa.
And I was able to push my car to reach right at 4 o'clock.
Anyway, it's fine. You made it, and
Yeah, I made it, yes.
we'll do that. Yeah.
Thank
Thank you,
you.
ma'am. Thank you.
Thank you.
Wish you all
Thank
the best. Yeah.
Oh.
Thank you, Dr. Deepa. Bye.
Thank you.